So thank you very much, Joe. That was a wonderful presentation as well. And so I'd invite both John and Joe to turn on their videos so we can see them. There you go. Hi, Joe. Good morning. And John's just checking in now, I believe. There we go. G'day, John.
Morning.
Look,
Morning, Joe.
Hey, John. Thanks, Peter.
First of all, congratulations on two very, very good talks. And I think what, for me, it's done is it's actually laid on the table an agreement that FAI exists and there are anatomical reasons why it should exist. And John, on your part, you've provided a structural solution to what surgeons see as a structural problem. And Joe, you've approached it from the look of movement, look of patient education, using other facets available to us from the qualitative side. What I'd like to start by asking both of you is, not everyone needs either physio or surgery. So how do you find the person who does have what is the structural abnormality and the physical and qualitative abnormality, who just doesn't actually need anything? How do you get them off the table in the first? Could I ask you, Joe, to start off on that one?
Sure. So I think what's really important to acknowledge is that the comment around structure and function and symptoms, that structure is important for some patients, but it doesn't seem to be important for all patients, in that there is now a large growing body of evidence that, particularly in athletes, the prevalence of CAM morphology and the associated pathologies that go with that, so labral pathology and chondral pathology, is high in both symptomatic and asymptomatic groups. So a systematic review was published several years ago now that showed around 2/3 of athletes will have CAM morphology. And some of my colleague Josh Heary's work, which was published late last year, showed that in a group of footballers, up to 3/4 of them will have CAM morphology, regardless of whether they have symptoms. So structure is definitely a problem in some people, but not in everyone. And we still don't understand who those people are or why it is important in some people and not in others. We also don't have a lot of good longitudinal data that shows us whether or not those people who are asymptomatic when they're younger, what happens to them over time. So do they become symptomatic? Is how much of a role does structure play in whether or not they are the people that go on to develop osteoarthritis? So Rinche Agricola's work from the Netherlands has shown that, and John touched on this, there's a number of studies that have shown that having CAM morphology does increase your risk of developing end-stage osteoarthritis and undergoing a hip replacement in later life. So the relative risk is there, in that it's around about a 10-fold increased risk. So that's really substantial. But when you look at the absolute risk, so you actually take the total number of patients with CAM morphology who do go on to develop osteoarthritis, it's still only between 5 to 10% of them. So not everybody who has CAM morphology, while the relative risk is higher, it's not everybody. The majority of people don't go on to develop osteoarthritis. So it is actually really hard. I don't think we have the answers yet to tell us who those people are, how we can identify them early, and what we need to do to try and stop that.
So can I just come back and say, then, if anyone presents with symptoms, you would treat them regardless?
Yeah, absolutely.
John, do you have in your mind the patient who would sit in front of you and you would say, you've got it all, there's the x-rays, etc., but no surgery or any treatment, you don't need it? Is there such a person? Is there such a group?
Well, I don't think they're likely to be sitting in front of me, Pete.
Yeah.
So if they've come because they want treatment, not necessarily because they want an operation, they've come because they want to get some clarity about why they've got pain and what they can do about it. So there's plenty of people I say, well, you should try to treat this with physiotherapy for a whole variety of reasons. In fact, pretty much everybody will have a period at least of physiotherapy to see if that gives them some relief before we even talk about operations. But in the majority, obviously there's exceptions, but the great majority, that's true. But I don't think there's anyone who I just sit and say, oh, look, you've got all these problems and your hip hurts, but you shouldn't have any treatment, goodbye. I don't think there is such a patient. But the first line of treatment would almost always be physiotherapy first, or some form of exercise therapy, or whatever you call it, but some conservative treatment first.
Yep. So in your mind, John, when you see such a patient with these constellation of symptom signs in radiology, are you treating them for the symptom that presents itself, or are you treating them for the long-term potential outcome of osteoarthritis? What goes through your mind at that moment?
What I tell them, and I say this to everybody, everybody I think of, but I think it's pretty much everybody. I say to them, we know there's a high probability that we can relieve symptoms to a substantial degree. Not in everybody, but a high probability. We'd like to believe that we can minimize the risk or delay the onset of arthritis later, but we most certainly cannot prove that. And that they should not regard that as a reason to do the surgery if that's what they're considering. So if that happens at this stage in our knowledge, that's a bonus. But the reason to have treatment is to relieve symptoms and allow return of function.
So Joe, from your perspective, when you're treating patients such as this, is it the symptom you're treating, or is it the long-term view? Because, the studies, as you've shown, do indicate that, the maintenance of a cam pincers, etc., do lead in a proportion of people to arthritis later. So what's your position on that?
I think, and I totally agree with John in that we don't know whether what we're going to do is going to change those long-term outcomes. So, excuse me, in the primary reason, as John said, I completely agree that a patient presents to you is they've got this problem, it's really bothering them, it's stopping them being able to live the life they want to live. And so that's what we're trying to treat. So very much treating their symptoms and their pain and trying to improve their function to get them back to the activities that they want to do now. So, a lot of patients have told us that it's getting back to sport and getting back to full function that they really want to do. So our number one goal is to reduce their symptoms and improve their quality of life and enable them to get back to what they want to do. In terms of preventing osteoarthritis, that would be the dream, to be able to do that. And that's what I think, that's sort of the holy grail for anyone, clinicians and researchers working in this space, is how can we stop these people going down that pathway of developing osteoarthritis. We know, and we really just don't have the evidence in the hip, but we do know that in the knee, there is, some evidence now that loading the joint in what would be considered an optimal or a healthy way is a good thing for the joint and can potentially reduce or mitigate that risk through appropriate loading and exercise and activity, because loading keeps the joint healthy. So I think a long-term goal in the hip would certainly be to try and optimize their function, and if you can, mitigate that risk. And that's what we're aiming to do, but I don't think we can do that, and we can't definitively say to patients that if you go and do your physio exercise program that we're potentially going to stop that risk, because we don't know. But I think trying to be fit and healthy and exercise is good for the whole person, not just for their hip, in terms of reducing the risk of comorbidities, cardiovascular disease, all those other things that we know really are enhanced by activity and exercise.
Before we go on to a little bit more on the education side, in joint replacement, for example, there are tools that you can use to identify patients who are unlikely to respond to joint replacement surgery, no matter what the x-rays show. And there's a whole variety of reasons that might be the cause. Is there anything in surgery, John, that, any tool that you apply? Because the study of CAM and outcomes have been going long enough for people to be doing systematic reviews and commenting on them and all the rest of it. But are there any tools to guide, the surgeon out there who wants to do hip arthroscopy and treat these, who they shouldn't be touching, even though they've got the full hand?
Not along the lines, I think, that you're describing. There are some obvious things that say that you shouldn't be doing it, and most particularly that's the presence of osteoarthritis in the hip. Yep. So, and there's a variety of ways of looking for that and measuring that, which are not, I don't mean sort of flat out to just about have your hip replaced type arthritis, but things way short of that, where we know that the outcomes for surgery in that situation are substantially worse and often not good at all. So that's an easy one that just shouldn't be done, unless there's some very specific thing like a loose body present in the hip, excuse me, or something that's causing very major symptoms of itself that can be eased, but you're not going to stop them progressively getting arthritis. In fact, you may even speed it up. So I think that's an easy one. But beyond that, so the sort of things that Joe's been talking about with the kinesiophobia and so on, which I guess they're the sort of tools that would be very helpful, but they're not readily available yet, or with good validation. But that's the kind of thing obviously would be extremely helpful, where you could say to someone, well, you've got these problems, but that we know that because you've got this, this, and this, that us doing an operation on you is not a good idea at all, and there are better ways to treat it than that. But we don't have that yet.
So Joe, just
Yeah.
on, as John raised, the educational side, fashion studies is really important, or it is pointing to that it should be very important. Could you just expand a little bit more on the components of education that you would look at, what to do, what not to do? What do you think is important of that facet?
Yeah, look, I think what John said, I really very much agree that it's being able to identify those people who are going to respond well and not respond well is really important. And we don't have a lot of strong evidence, but I think trying to educate people about the importance of, regardless of whether they end up going to surgery or not, they will need to move and to exercise, and restoring that, trying to restore as close to normal movement and function around the hip but in the whole body is really, really important. So really encouraging them to continue, to build it into their lifestyle so that it becomes a normal part of keeping fit. So in the same way that we should encourage all of our patients with musculoskeletal pain to try and meet the physical activity guidelines, we can build that into what our patients do. So whether we're rehabbing someone post-operatively or we're providing non-operative care, we need to try and encourage people that, they need to meet their physical activity guidelines of 150 minutes a week of moderately vigorous physical activity. They need to do at least 2 strength training sessions a week and incorporate the things that we know are going to be good for their hip into that more whole body program. So I think that that's really, really important, because people are frightened to move and they think that moving is going to cause more damage to their hip, and the qualitative work has shown that. So trying to help them get over that fear, and whether, as I said, whether they've had surgery or not, encouraging them that it's, to move in a safe and healthy way and not be frightened of movement is really, really important. And that doing no movement is probably as bad as doing too much movement, and the right amount is somewhere in the middle. So I think that's the biggest thing, is really getting them on board with keeping on moving and keeping on doing their activity, and also not helping them get over their fear of pain as well, because there's a really strong fear of if I feel a little bit of pain in my hip, I must be causing more damage. And we don't know whether that's true or not, but we do know that in other joints that the relationship between pain and structure is really, really poor. And we think that it's probably similar in the hip, so that it's actually okay for these people to have a little bit of discomfort and a little bit of pain. Obviously, we don't want a lot of pain, but what these patients often do is as soon as they feel any discomfort or pain, they just stop and they stop doing anything. And I think that potentially makes things worse as well. So it's helping them get over their fears, regardless of whether they have surgical treatment or not, to be able to move in a safe and healthy way.
So John, thank you. So John, educating them to not fear, but they come back to you and say, but doc, I've got an egg-shaped femoral head and it's supposed to sit in this circular hole. Surely that couldn't work. How do you deal with that if that is actually one of the drivers of the fear? How would you approach that, John?
Well, it depends what I want to do. So if
would you reassure them that it's okay, that there's 2/3 of sports people do have an egg-shaped thing sitting in a round cup? I mean, I guess it's
I do. Yeah, I do. So I point that out to people, but they often have it in their mind that they have, and lots of these people have really quite severely painful hips, and some of them have been trying with various physiotherapists for 2 and 3 years to get better, and they still can't do what they want to do. So I'm taking extreme examples, but so with them, when they say to me, I've tried all this stuff and everyone tells me they'll fix me, but it doesn't, and I've got this egg-shaped thing trying to get into a round hole, and obviously it's never going to work. Well, then I say to them, yeah, well, there's some truth in what you say, but then I do point out to them that a lot of people, as you just said, have that and don't have a problem with it. So it's not necessarily just the fact that it's there that means it has to be treated. In fact, that's not the case at all. but that if you have sufficient symptoms that are not recovering and you've already got some damage in your hip that's likely to get progressively worse, and it's well shown that a bigger cam is more likely, or Joe put that up before, and I agree, that it's been shown that it's up to 10 times more likely to progress to arthritis. And that's only over relatively short-term studies as well. So over long term, who knows what it will be. Then you get to a point where you say, okay, well, I think it's perfectly reasonable that you should try an operation to fix this. And here's the likelihood that it will work, but be absolutely aware that it may not. And that you go through all of this and you end up back where you started. But the risks of that are relatively small, but they're there. So I give them numbers if they want them.
Yeah. So Joe, there you are, you're treating someone who is complaining about the hip. At what point do you say, look, I need you to see John O'Donnell? At what point do you say surgery is the thing for you?
I think this is the key question, and just looking at the chat and some of the questions in the Q&A function, that there seems to be some debate around this, is that while not all patients will need surgery, there are a portion of patients who will, because they, with the best non-surgical care in the world, they still don't achieve the outcomes that they want to achieve. So as John said, there is a little bit of evidence that shows that the people with a really large cam morphology who have symptoms probably don't respond as well to the non-surgical treatment. So there does seem to be a relationship between how big the structure is and how well people will respond. So, but I would always expect, whilst best practice physio treatment should be sort of 3 months, but even up to 6 months, it doesn't mean you treat them for 6 months and not see any improvement. So you really should be starting to see improvements within the first few weeks of their treatment. I think within the first 3 to 4 weeks. And if they're not improving, then I would change direction. And part of that change of direction might be referral to surgery.
So can I just say, so no matter how severe the cam lesion is, you would put them through all the physiotherapy moves and they have to fail that before you go to surgery. Is that the message? They should be doing all these things first before they get to the surgeon?
It's good. That's a good question. It depends on what your definition of fail is, in terms of what failure is. But, in our cohort, in our large force cohort of footballers, there are asymptomatic footballers running around with cam morphology, with alpha angles in the 80s, even up into the 90s, with huge cam, big cam morphology. But I think that I think the other thing we've got to remember is that by the time people come to see me or come to see John, they've had their pain often for months and months and years, and they've often tried multiple things. So with those patients, I'm not going to keep banging on at them for 6 months without seeing some sort of improvement. So, you really, I think probably, a month to 6 weeks, if you're not seeing any change at all, or if patients are continuing to deteriorate, that's the point, in spite of me and the patient doing our best to try and really give them what we would consider best practice physio treatment. That's the point when I would start the conversation with, okay, we might need to look beyond physio to help you manage your condition.
So John, as a surgeon who's super specialized in this area, your referral pool presumably would be patients at the end stage of a whole series of different interventions, or you receive the referrals from other specialist orthopedic surgeons. Do you have a group of people who, and I go back to my earlier question, where you would see them and say, well, you don't quite fit the you must have it, or I can understand why nothing's going to work. You actually part of that group that, well, maybe physiotherapy will work, despite knowing that surgery could be an intervention. And do you actually, I guess the point I'm trying to tease out is, when you get the patient, do we operate on the patient, or do you stop and say, well, the evidence does say if you're this big, you're likely to end up requiring surgery. So look, I can give you the green light on that one. But this one, although you got a cam lesion, it's kind of, maybe you can wait a little while longer and, you might stop being out, who knows, maybe we'll try something else. Do you ever find yourself in that situation?
Yeah, I do. But I would certainly take into account there's some published evidence that delay of more than 6 months in treating these will lead to poorer outcomes, treated with surgery, I mean. So there's a whole variety of things that come into that decision. And I think I certainly don't suggest everyone should have an operation. who's got a painful hip. And I'm not pushing that for one moment. But I think that prolonged delay is not a great idea either. So I think there are times where it's very appropriate to go ahead with surgery at a relatively earlier stage. So I'll give you one example. We have an 18-year-old where with his first hip, he's already been through a year's worth of physio, and it hasn't helped him. And I appreciate there's physio, and there's all of these things that have to be taken into account. But assuming that it's been high quality from someone who I trust, and we do the operation, and all the imaging before has been not too bad, but he has really serious damage at 18 to the articular cartilage in his hip, and we see this. This is not rare. And he's got the same morphology on the imaging of his other hip, but at this stage, it's only got relatively minimal pain. Now, you can always provoke a bit of pain by twisting hard enough, but with those people, I've really come around now to talking to them about the need to strongly consider looking at their other hip, because the first one's already really severely damaged at a very young age. And what we've shown a long time ago is people who have their second hip done, even though they're symptomatically not as bad, that the pathology in the hip is at least as bad and often worse in the second hip because it's been present for longer. So we're trying to take all of these different things into account without adequate sort of long-term evidence, and to do the best we can.
Sure.
And so it's a challenge.
Yep. So as we finish, I have one 10-second answer from each of you. Joe, if one of your colleagues receives a patient with symptoms and signs of FAI, what is the one sentence you would tell them of advice?
Oh, geez, it's a hard question in one sentence. I think I would tell them we need to find the best treatment for you, the most appropriate treatment for you. But regardless of what that appropriate treatment is, it's really important for you to continue to move and continue to exercise in what is a safe way for you to be able to do that.
John, if an orthopedic surgeon coming up through the ranks wants to do hip arthroscopy, what is your one 10-second word of advice to them about that, and Cam?
If they're going to do the surgery, to be well trained in how to do it well, because you can make things a lot worse very easily. And especially if you're a labrum destroyer, which some surgeons are, then I think it's really important to be trained really well, both not only in how to do the operation, but in when and who and what the other options are, which you've heard this morning.
Good. And with that, I'd just like to thank both Joe and John for giving their time this morning. That's been a really, really interesting exploration into this very controversial condition. So thank you very much on behalf of the committee. Over to you, Sid.
Great. Thank you, Peter. Thank you, John. Thank you, Joe, for that great start to the day.